Today on Out of Network, we're joined by Dr. Joshua Goldman, a board-certified plastic and reconstructive surgeon in Las Vegas and co-founder of the Vegas Plastic Surgery Institute, whose career sits at the intersection of complex surgical training, academic leadership, and the growing movement toward concierge-style care. Dr. Goldman is a Stanford University graduate with honors and a former varsity NCAA gymnast and an All-American Scholar athlete. He earned his medical degree from Texas Tech University Health Sciences Center School of Medicine before completing his plastic surgery training at the UNLV School of Medicine. He went on to pursue advanced subspecialty training in craniofacial and microsurgery in Royal Oak, Michigan. After serving as assistant professor of plastic surgery, vice chair of clinical affairs, and head of extremity salvage at UNLV Health, Dr. Goldman went on to co-found the Vegas Plastic Surgery Institute just to elevate reconstructive care in Southern Nevada, particularly for patients undergoing breast cancer reconstruction, building a practice designed around continuity, precision, and individualized attention. Dr. Goldman's goal closely mirrors that of the concierge physician, delivering first-class surgical practices in highly personalized models that prioritize time, access, and outcomes. We're excited to explore how this approach is redefining plastic surgery today. Dr. Goldman, thank you so much for being a guest here on Out of Network.
My pleasure.
I have to say, reading your credentials makes me feel like I've done nothing with my career or my life. So I
hope you had more fun
of you. So I'd like to kind of take a deep dive. So you went from being an All-American scholar, a Stanford gymnast, obviously a tremendous athlete and scholar. What really drove you into being a plastic surgeon?
Yeah, it's a good question. I started out kind of, it's sort of cliche to say when you're applying to medical school that you like science and you want to help people.
Yeah. We all say it.
Yeah. But that is the foundation of all of it, right? I mean, I loved science. I loved, sort of the discovery of new ways to care for people. I loved the research aspects of it. And I wanted to bring my life meaning by taking care of other people. That's, a warmth I think that was instilled in me by my parents.
Any parents or family members in medicine?
Yeah, so my dad's actually in law, but my mom and my grandmother were both nurses.
Oh.
And so, obviously a caregiver aspect to that, and also instilled in me a great appreciation for what our nurses and staff do at the hospitals. And so I kind of grew up in that space. I went to, if I was sick at home, even during like elementary school and things, my mom was a home health nurse, so she would go around town, on the more impoverished sides of San Antonio, where I'm from, and give diabetes meds and do wound checks and things like that. So we were going down to the south side, and I watched her take care of 60-plus-year-olds, and it really it made me think like, oh, I want to do something that means a lot. And I saw the way that these patients really appreciated what she was doing, and it brought a lot of value to their lives. So I wanted to follow in that.
Yeah. So craniofacial microsurgeon, I don't even know what that means.
Yeah.
Can you talk to me?
Absolutely.
That. What is that?
So we'll kind of break it down into two. I mean, craniofacial is simple. It's anything in, sort of above the neck, both the cranium, so cranial vault, any skull-based issues, particularly in the pediatric patient. So people or babies whose sutures have fused too early, will remodel those so that their brain has an ability to grow. What you most commonly would know is things like cleft lip or cleft palate. And those are the things that we're doing on the craniofacial side. My fellowship director married that with the microsurgical side, which is a little bit more complicated. So when you're looking at complex reconstruction overall, we're typically talking about it on a elevator or reconstructive ladder. So you start at the most basic, right? Wound healing, primary closure, like suturing a wound together, all the way up to the most complicated, which would be what we call free tissue transfer. And that's the microsurgical side. So that's taking a part of your body and transplanting it to another part of your body. Obviously, it doesn't require any like immune therapies because it's your own body. Yeah, correct. You won't reject it. So the most common that I do now in my practice is breast microsurgery. And so that's taking people for breast cancer. And so patients with breast cancer that had a mastectomy, had their breast removed, we'll take their lower abdomen. So we take the skin and fat with the blood vessel that supplies that skin and fat, take it up to their chest, find a blood vessel in their chest. We take a small piece of rib out and plug that together under a microscope, which is why it's microvascular. Wow. And now it's living tissue. And so they don't need implants necessarily. They have their own tissue. Most people are happy to donate their lower belly to the breast. And so we're able to reconstruct them in, a sort of novel way that doesn't require implants or foreign bodies.
Fascinating.
The more interesting side of that, even past those kinds of reconstructions, is the head and neck reconstructions that are both, form and function. So people who've had maybe a squamous cell cancer of their jaw, so they've lost their, mandible, lower jawbone, or even, more complex structures, will typically take their fibula, so their outer leg bone, which is only about 5 to 10% of your weight-bearing capabilities, again, with a blood vessel, and we'll plug it into a blood vessel in your neck, reshape that bone three-dimensionally to reconstruct the jaw. And you can even, particularly with the fibula, you can even put dental implants into it. And so we do that for all types of benign tumors and cancerous tumors, malignant tumors. And so that was that three-dimensional capacity to change, the ability to restore jaw function, the ability to restore breathing and things like that. We do that for tongues. We do it for noses. That really drew me to that field. Originally, I was interested in medical oncology. So that was my first passion, both in undergrad, where I did my honors thesis in bone marrow transplant. And then in medical school, I continued that, working with a real giant in that space. One of the guys who was on the original paper for Gleevec, or imatinib that is good for CML. So he was one of the godfathers of CML. And I spent 2 summers doing research with him. And then the second summer, he was like, "Can you come to clinic with me?" And I was like, "I would love to." And so I came to clinic with him. And it was the first time I was like, oh man, I loved the research behind it. I loved the research of immunology, but I was not built for direct cancer care.
Yeah.
The patient admiration of him and the relationships that he was building with patients to occasionally see them not make it through was a lot. And I realized I couldn't really make my life about that.
Right.
So and I have the huge admiration for the people who do that. And so I kind of started looking at other specialties. As an athlete, a lot of my friends were going into orthopedic surgery, a lot of emergency medicine.
I was going to say, not to be stereotypical.
Yeah. No, very, very common. Yeah, my best friend's a spine surgeon in Texas. My wife's an orthopedic trauma surgeon. And so I looked at ortho. It was a little bit algorithmic for me. I looked at dermatology, not my thing either, although I did Mohs reconstruction. And then I tried out plastics, and particularly I went and did a rotation at Sloan Kettering and saw some of the complex, crazy reconstructions they were doing for tertiary level cancers. And I realized I could still tie my life to cancer care, but beyond sort of the back end of it, where I was changing people's lives and getting them back to who they wanted to be, making them feel whole again. And it just felt like the right place for me.
Pretty satisfying, right?
Really satisfying.
So tell me, is this so we do 4 years of undergrad, 4 years of medical school, a 5-year plastic surgery, 6-year plastic surgery residency, and then obviously it's a fellowship.
Yeah, so a 1-year fellowship for any subspecialty outside of plastics. Okay. So plastics,
that's what you did in Michigan.
Yeah, so plastics has 2 pathways actually. So you can do a 5-year general surgery or ENT or ortho, and then go into a 3-year plastics fellowship, and just to become a plastic surgeon. And they have an integrated plastic surgery fellowship or residency, where you just go straight from medical school and you do 6 years of plastics the whole time. A couple of the programs are 7 years. And then you can subspecialize in things like microsurgery. Aesthetic fellowships are very common. Craniofacial. Mine just happened to be an integrated kind of between the two.
Right?
Yeah. Okay. And then and then hand surgery is also in the scope of plastics. So that's another 1-year fellowship.
Tell me how competitive that is to get into.
I think if you look at by the numbers, you're looking at almost always a top 3 for integrated in particular. For that 6-year residency program, you're looking at, and that's both by match rate, by, scores, things like that. And so, and I'll be honest, I still sit on the, group that looks at and interviews the residents, the incoming resident in our program, here where I train. And it's 1 a year. So we only take 1 person a year. I feel really fortunate to have been that person that, what feels like a long time ago now. I hate to say how long ago. And
I see some gray hair for Goldman.
It's getting real, yeah. but seeing these young people come out and their scores are tremendous now. The dedication to research has just ballooned, particularly as that's gotten more and more competitive. I'm seeing people with 20 plus papers be the commonality. When, there was a paper that famously came out when I was applying that basically said the difference between 0 and 1 paper was massive in terms of how many interviews you got. So if you had none, you got very few interviews. If you had 1 paper, it would jump you to 9 to 10 interviews. But if you had 9 papers, it didn't really make a difference.
Right.
I would say that that's not the case anymore. And they're finding that like there's this tremendous need to sort of differentiate yourself among this already excellent group of applicants. So challenging.
I mean, how do you delineate between the person who is academically savvy, who has written papers, published, but if I want a microsurgeon, I want someone who has the skills and the dexterity. I mean, so how do you weed those physicians out to do that? And I guess to bounce off that question, do you think being an athlete is what gave you those surgical skills?
Yeah, I mean, I think like if you look at, one of the buzzwords now is grit. So we're looking for people who are going to make it through a challenging healthcare environment, both in terms of training and in terms of when you get out in the world.
Right.
I think that, you do have to sort of differentiate between what we call like sort of disaffectionately like library surgeons and, actual surgeons who are going to get the job done.
Absolutely.
And then you see, I think as you get out in the world, you start to see, I had all these heroes, the guys who wrote all the books. They might not be operating as much. And then you find these like kind of private practice guys who are, knocking out crazy volume in crazy complex situations and doing extremely well. And so those are really who you're looking for, I think, a lot of the time. And so one of the things that we look for, and I talk about my wife, who's also very involved in her residency program. I used to say like, I would prefer people who rotated with us because it's easy to fake a 15-minute interview, very hard to fake for a month.
Absolutely.
And so I want that. I want that person. I tell every applicant that once they've gotten there, I'm not really looking at their application anymore. They already kind of crossed all the T's and dotted the I's. I'm looking for somebody I want to hang out with at 2 in.the morning for a replant that's going to take 9 hours, and somebody's going to take care of their patients and care about them. Right. I sort of look for people who've had a job, in their lives, whether that was retail or otherwise. And then the people who really like, it shows an ability to, be able to survive in a hierarchical world of authority, and also to be part of a team. Those people who've lived those experiences. The one caveat being, if you've been an athlete, you have done that usually.
Absolutely.
I was a gymnast. It's an individual sport, but everything I did, even from the time I was young, was so that our team won state or our team won NCAAs. And we were part of a group that cared tremendously about each other. We helped each other out. Those things are meaningful. It's your ability to kind of give all of yourself to a very specific training model and to just seek excellence in everything you do, which, kind of like we've talked about, is the expectation now. And so it definitely impacted me. And it is something that I very commonly will look for in our applicants so that we can make sure we're getting the best people for the future of healthcare.
True.
And it's not just, I think when people say grit, I would say like, I kind of, grit has become such a buzzword. I hate saying it, but
it's true.
It's almost resilience.
Right.
And you'll build some of it during residency, but you have to start with some of it too, usually.
You do.
Yeah.
And I think, and often it's not often trained. You either have it or you don't. And I think especially where graduate medical education is coddling residents more and more and more.
Yeah.
I think it takes definitely a skilled, precise individual such as yourself to do what you do. So
I appreciate that.
Honestly, I'm in awe. So I have to ask, and a lot of people wanted to ask this question, what's the one unique thing, I guess, that sticks out in your mind that you've either seen, taken care of, that just you still think about?
We've done a couple of, pretty insane cases. We used to joke that there's a lot of things that only happen at like MD Anderson and at VPSI.
Right.
As I'm sure you're aware, like Vegas is sort of a desert for healthcare, and definitely on the complex side. It's interesting if you look at plastics. People will say we are underrepresented in every single medical specialty except plastic surgery. And that's true by number of plastic surgeons, but the vast majority of them are only doing cosmetic surgery or largely cosmetic surgery. And so there was huge opportunity when I came out here or when I came back here after training. And so one, we just published, me and my partner did the youngest, what's called a lower leg free fillet flap, in a patient with a sarcoma. So a big cancer of their thigh. They have to remove the entire thigh and half the pelvis. So a hemipelvectomy, leaving exposed the abdomen. So, it's fully open to the intestines and, even the inguinal ligament is gone, things like that. So we put a big mesh there, and because the thigh is bad, but the lower leg is good, we actually debone the lower leg, take the major blood vessel that's attached to that, so the popliteal vessels, plug those into the iliac vessels, which it's not even microsurgery at that point. That's almost basic vascular surgery.
Absolutely.
But on an 11-year-old, so it's very high stakes. So we put a big mesh covering the bowels.
Following trauma then?
This is a sarcoma, so a big cancer of the thigh.
Okay.
And we've done similar things in trauma. All of these things kind of inform themselves over time. This is an 11-year-old. And because he's smaller, it's more challenging. The body is smaller, and we have like 6 surgeons around doing the extirpation and the reconstruction. He actually, the flap became venous, so it had good arterial inflow, but not perfect venous outflow. And so the flap becomes a little bit purple. So that's that whole tissue that we use to cover this space. And one thing that I hadn't thought about prior was that we didn't do a bowel prep. And every time he got constipated and the bowel distended, it was pushing on the vein that we had hooked up. And so, we did good bowel preps after that. We actually leached the flap just to make sure it was getting enough outflow to maintain. It ended up surviving and doing really well. He got fitted for a prosthetic, and which is challenging.
It's done in Las Vegas, Nevada.
Yeah,
in a city and a state that we're often looked down upon as physicians, right?
Oh yeah,
thinking that we do not have the capacity to do these complex surgeries.
There are amazing surgeons doing amazing things here. Amazing physicians taking care of very complex situations. I think we continue to struggle with multidisciplinary care and building systems. And that's been sort of our charge. That was one of the things that sort of drove us to building a practice, was programmatically. When I first came to town, I was adamant. Any patient that came through the door, I was like, look, I trained so that I can fix any hole that an extirpative surgeon makes. So if an oncologic, a cancer doctor makes a big hole in your head or face or other part of your body, we will fix it. We will close that hole to the degree of any tertiary or quaternary care center in the nation. That was how we trained.
Amazing.
I wanted to be able to say yes. It was a sobering moment when a patient came in with a problem that we could fix, but coordinating the care between the neurosurgeon, the surgical oncologist, myself, his medical oncologist and radiation oncologist was such a delay in care that the tumor spread. And, and he ended up passing away before we even got to the surgery, unfortunately. But that was the first time I was like, well, I may be able to do my part, but if we can't get it together as a team, I would never after that tell somebody, don't go to somewhere with a team.
Right.
And then that was sort of like when the point where we were like, all right, we got to build a team. We got to start
that system in place,
getting that system in place so that our skills can shine the way that they need to. And really for everybody in the community who's doing really good work and continuing to evolve, but had struggled in that sort of way.
Yeah. So you're the co-founder of the Las Vegas Plastic Surgery Institute. Can you tell me a little bit about that?
Yeah. So me and Dr. Brochus, we were actually, it's interesting. He was my chief resident when I was an intern. Then he left for Pittsburgh, where he worked at Pitt for as a sort of private-demic surgeon.
Sure.
As a private-demic surgeon for a few years. Unfortunately, our chair and our hand surgeon, in about the span of a year, passed away when I was in residency, and so he actually came back to kind of help rebuild the program. I thought I was going to get shipped off to Wisconsin or something, and so I was like, man, we're done. Like, that was 2 of our 4 surgeons. Who were our training model. And so I was like, I'm out of it. Like, the ACG media does have a requirement to send you somewhere. And I was like, I'm going to end up in like Idaho or, like they're going to uproot me. And I was really, really fortunate that Dr. Brochus came back, and he was my program director. And then I went off to fellowship, came back, and I was his partner. And then about 3 years into the academic practice, I felt like there were barriers that I knew there was a lot of opportunity in Vegas in terms of healthcare. And I thought there was a lot of opportunity at UNLV to like really build something amazing and special. And there were so many obstacles and barriers that we just couldn't overcome there, that eventually I kind of like started nudging him and being like, hey man, we gotta do something, or we're not going to get to the point where I think what we could be are capable of building. And so we started the practice, sort of like we were talking about before. We told the dean when we left that, you took 2 people with 0 business acumen and made us certain we could do it better. And we certainly we hit a lot of I tell people we worked really hard and sort of made our own luck, but we got a lot of luck as well.
Trial and error.
And, when things got, challenging or were going the wrong direction, we pivoted a lot in the early phases. The goal though was to build a care model that was ubiquitous, where we could take care of a lot of patients both, in terms of socioeconomic variability, as well as at the highest level of complexity and at the lowest, and on the cosmetic side, and provide something that really wasn't available in plastics.
Yeah, incredible. So this is a referral-based practice primarily?
Largely, yeah.
Okay.
On the cash-based side, it's mostly aesthetics, and so patients may find us through marketing or word of mouth and things like that. On the breast cancer side, which is about 60% of my practice now, it almost all comes from either the OB-GYNs who are ordering mammograms, or the primary care doctors, or the breast oncologist or the medical oncologist themselves. So the vast majority of our practice is really making sure that they feel like we are accessible. I was really adamant about time to care. I think that's, like I said, programmatically, some places fall behind in that. If you go to major cities elsewhere, you get diagnosed with cancer and you're in the OR in 2 weeks, and here it might be a month before you see the other oncologist or the other person involved in your care. So for us, we were really adamant that, within the time of receiving a referral, we were there within one to two clinic visits. So within a week, you can see us for a stat, within about 2 to 3 weeks, for a non-stat referral. And so the whole thing is accessibility, making sure that we're never the reason that somebody's cancer care is getting delayed. And then really building something that was, we have the luxury and the sort of concierge feel of an aesthetic practice, or at least that's the goal. But all of the access and care models of insurance-based practices, which is sort of challenged because the pay is different, financially it's different, the economics of it are different. The overhead is actually, probably the most challenging part, because a huge portion of our overhead goes to the administrative burden of getting through the insurance system.
100%.
And so when the
system doesn't set us up for success.
Absolutely. Absolutely. And so if you're like, well, I have to have 3 extra employees just to get paid, you start moving away from that model. And I think that's one of the things that sort of led to the concierge model.
Correct.
You can pass along those savings to the patient when you don't need them.
Right.
But when you're fighting insurance constantly, which we are, so we wanted to find a balance between those things. I think, one of the reasons we never went full cash or full out of network is because some
patients that need you, obviously, for these
absolutely
surgical,
and those things can get cost prohibitive. And so, like I said, I have a spine surgeon who is all out of network, and at the high end, patients can pay those prices. But there are some of these surgeries that are just cost prohibitive. I mean, less than 1% of patients could pay for having these big major surgeries where you're in the hospital or ICU for several days. And you have a big care team and it's a 10-hour OR. And so, a lot of patients can't pay 6 figures. So you sort of have to find a way to make insurance work, or you're not going to be able to do that care.
And what you're doing is providing excellent access to patients that need it. How much of your practice is insurance-based then, did you say?
Yeah, so we're still, I do about 20% aesthetic or cash-based surgeries. The remainder is insurance-based. But that is a smattering of in-network, which is the majority of what we do. But with significant, aggressive negotiating, and then out of network, where we get gap exceptions and single case agreements with insurance companies. And then a smaller fraction is, arbitration and IDR kind of.
How often do you find that you identify that a patient needs a certain procedure and it's denied?
Oh, I mean, if I can walk you through what the worst case scenario is, and it happens commonly. So it would be, and I tell people, if you're on a cash-based plan, if somebody comes in and they say, I want a breast augmentation, then I say, okay, yeah, you're a good candidate for breast augmentation. And they say, how much does it cost? I say, it costs X. And then they say, all right, they give you the money, I do the surgery, everybody goes home. On the insurance side, I say, they come in, they say, I have this problem. And I say, we have a fix for that problem. Then we get an authorization. That authorization gets denied. Then we appeal the authorization. We come back, it gets denied again. I do a peer-to-peer.
We're not talking days, we're talking potentially weeks.
We're talking weeks. I do a peer-to-peer, which some of the insurance companies have stopped giving us times for peer-to-peers, and we'll give 2 days where I have to give them 2 days where I'm available for 4 hours at a time, which, as you know, is very challenging. And so I'm answering all my spam calls because I don't know, when that insurance company is going to call me. So we do a peer-to-peer. Let's say it gets authorized now. It's authorized. Every authorization is not a guarantee of payment. And so we do the surgery that's been pre-authorized.
I don't think a lot of patients realize that.
Absolutely. And it's an asterisk, and we bring it up, and we have forms to make sure that the patients are aware. But like all things, it's for the layperson to understand the intricacies of those, it's impossible. And I would say that that's by design, right?
Meanwhile, like you alluded to, the costs of the overhead and the expense and the OR time and
Yep.
who you were paying.
Absolutely. And so they'll authorize it. We'll do the surgery. We'll say we did the surgery. This is the surgery that was done. We send our, op notes or otherwise, and they'll deny it, saying, well, you shouldn't have done that surgery. We're like, well, it's pre-authorized. Then we, appeal it. They deny it again. We appeal it. We get the money. Then a year later, they'll say, actually, we were auditing you, and they'll take the money back. It's a recoupment. And so
how often does that happen?
It's a shocking amount to me, but probably have some recall bias because.
Can you not fight that?
So then you fight it. But the problem is that the way that insurance contracts are set up is that recoupments are taken from other payments. So I always think of our biller like a conspiracy theorist in like our back room with like red string tying all the payments of where they go. Because what they do is, let's say it was $1,000, they'll take $50 payments from copays for visits. So we have to credit and debit all of those payments that have been pulled. Then she has to, once we appeal it and get the money back, she has to re-credit and debit all of those accounts so that they're appropriately accounted for. So, that's the longest version of it, and it happens, significantly more than I would like to say.
Meanwhile, taking away who you bring to the operating table, the skills that you have, you are fighting all this administrative BS.
Yeah, it's an administrative burden, and that's, I think, leads to a significant amount of the burnout that, and really people's disillusionment with healthcare, both on the patient and physician side, and also people's fear to go into private practice. Building a business where, maybe next month somebody pulls back significant amounts of money from the practice, just like essentially out of your bank account. That's not something you can rely on. And so we have to build kind of complex systems to deal with those things. We got one of the places we were really lucky was that we ended up with a biller who is so sophisticated and our greatest luxury. I always say, like, she's our greatest luxury, and then having a partner that I can trust and know what I get from him, and we're both hard workers, we both care about patients. That's also difficult to find. Yeah. But I think, the goal always was to build something, obviously starting out, that would benefit our patients, our staff, ourselves, as human beings and caregivers or providers, and really to build something for the future.
Right.
I think if you look at plastics in general, the vast majority of people coming out of residency think there's two options. You can go be employed or academic so that you can do reconstructive surgery, or you can go be private and do a huge portion cash pay cosmetics. And we're trying to show there's like actually a third model. There's this sort of private-demic model. We still are engaged with academia through training residents. I still do research. And we built a system where we can take care of complex problems, the ones that interest us, and do well enough on the cash pay side and the out of network and insurance side that when a patient comes in and they don't have the right thing and they're a good person who needs care, particularly in the pediatric space, we just take care of them. And that's probably our greatest luxury as just human beings and people who wanted to do that. It goes back to being a med student and liking science and wanting to help people.
At the beginning,
yeah,
people just want someone to have ownership of their care and health. And I can't say it enough how frustrating and challenging it is for us as physicians for patients to understand all the hurdles that we have to jump through just because we truly care about our patients.
Oh yeah, I think if the reception side of our practice, I always tell our receptionists, like, don't argue with anybody in the front lobby. If somebody has a problem with their insurance deductible or their copay, just have them come into the room and I'll talk to them. And I get it. And I tell them that. I have a conversation almost probably like once a month with a patient who is just visibly upset. And I'm like, look, you paid into an insurance premium your entire life. You're a healthy person, so you never used it.
Right.
And today you needed it, right? And, and you've gotten bad news. You're usually seeing us on either the worst or best day of your life.
Right.
You've gotten bad news, you need care, and you're finding out now that even though you've paid into this your whole life, you still owe a lot of money. Right. And I sincerely understand that. But if we don't collect these things, I can't keep the lights on for the next patient.
Right.
And most people, once you kind of have that calm conversation, that you are all working towards the same goal and that there are these like externalities that you're all kind of just trying to function in, you find that common ground and they calm down and they understand and they're happy to work with you and, get it done. And like I said, we've been really like fortunate to be able to put together a practice where we can kind of take care of patients and find balance in different spaces. And to a point where we're like, we still want to do the things that give us the warm and fuzzies. It's still part of our payment, and still keep us intellectually curious and interested, and build a place where people who want to only do those things, hopefully someday can do those and take on those parts of the practice.
Absolutely. Patients don't often understand the language of their insurance contracts, and oftentimes we are the punching bags, and we're not privy necessarily to the information of that specific contract. But it's frustrating that patients truly are paying more and getting less.
Yeah, I mean,
see it all the time.
There's no face to it for them, and we become the face. We become this sort of odd middleman. And our biller, the same one I was referring to earlier, she's sort of become this sort of like helpful hand in explaining those things, almost like an insurance navigator. But if you can imagine, that's at huge cost to the practice. And we all went into it to take care of patients, not necessarily to like push paper around all the time. And I think that is one of the big deterrents for being in a private world and trying to
Sure.
sweat and get through the insurance world, and people turn to other models. And I never I think early on I was like, man, how can you go be all cosmetic? That's like messed up. You spent 6 years in federally funded programs,
Right.
and then you're going to leave and just not take care of people who need you. You're going to do, rhinoplasty and then once I got out in the world,
Charge $20,000 for
right,
it.
exactly. And and you drive a Ferrari, and that the sick person with the cleft lip, or otherwise doesn't get care. And and sort of slowly I realized, like, well, there are people who are passionate about that type of surgery, and they're fun to do, and we have aspects of our practice that are that. And B, it's otherwise extremely challenging. And I sort of stopped dogging on other people's hustle and started trying to figure out my own, and making sure that, we built a system that we wanted to live in and wanted other people to be able to live in.
Yeah. It speaks highly about your character, and I applaud you. So, I've often been compared, concierge doctors compared to a plastic surgeon such as yourself. We deal with a certain level of clientele, and I'm probably just talking more about the aesthetic side than anything, but how do you continually raise that bar? Obviously patients expect access, personalization, results, and there is a certain bar that we set, but obviously you see that bar continually has to get higher and higher. So
Sure.
how do you?
I think, a couple things. One, we're continuously learning, right? So we try to stay abreast. My fellowship director, one thing that really stuck with me is he always said, don't be the first and don't be the last to do anything. And so, kind of wait for the bugs to get worked out, and then really integrate, newer things into our practice all the time. I agree. I agree that the cash pay side, I always tell, residents, if somebody, if somebody pays you $20,000 for an aesthetic surgery, they bought your phone number. And they better have access to you in the same way that, some of the subscription concierge models literally bought your phone, and so, I think that's
Just a contract.
Yeah, exactly. That's not always the case in our side of things, but I think it's still the expectation. So you better deliver on that expectation. You better have that availability to those patients. And, you may run into your clinic at 9 o'clock at night to take a look at somebody's chest. Even if it seems silly, it may need, a little bit of hand holding, and there's a high maintenance aspect to that care. That's the give and take, on the insurance based side, it's more insurance, headaches. On that side, it's more, patient expectations. And so you do everything I can, everything from making your office aesthetic to, nobody should come into my office and not be offered, water or sparkling water. And, and that's regardless of whether you're an aesthetic patient or a Medicaid patient.
Right.
So, and we kind of toe that line.
Sure.
Interestingly, I think in breast cancer reconstruction, which is mostly insurance based, there's been almost a total flip. And we actually kind of like package into our practice model, it's like aesthetics and breast recon is in that side of things. If you look 15 years ago, even 10 years ago, probably, my mentors, the people who taught me, would say, our goal in breast reconstruction is to make you look okay in a shirt. You can throw that out the window, now. Our goal is to make you look sometimes even better than we started,
Right.
and that's slowly become the patient expectation. So I think having really long conversations about, what are our goals? Are we going to be able to be the silver lining of your breast cancer experience? What are our limitations?
It's really setting those expectations ahead of time.
Yeah. And honoring them, right? And like getting, and sort of delivering on those things.
Right.
It's hugely meaningful. I think building, again, sort of systems, we built out our breast micro program all of our patients go to a surgical suites area. They're in individual rooms. This is still insurance based, it's not like we made sure that there is some experiential aspect to it. And that kind of keeps our practice going. But the expectations of the patients continue to evolve on that aesthetic side. And so you have to be willing to kind of meet them. I think you also have to be willing to have those conversations that are sometimes harder. Say like, hey, this is what we can do. This is, I want you to have a realistic expectation. These are the places we're going to have complications if we're going to have them. So that they expect them. And it's not, if you tell somebody about a complication before, you're Nostradamus. If you tell them about it after, you messed up. And so we really try to have those conversations, and that bleeds into, sort of the volume of your patients, right? Most people who are insurance-based practices are going to try to make it up with volume. And you can't do that if you're going to have
the quality
long, meaningful conversations with people, if you're going to discuss limitations, if you're going to discuss options in a meaningful way. I mean, on the breast reconstruction side, one of the things we run into is we offer that microsurgical side. There are a lot of people who do not. And so, having a frank conversation about all of your options is different when you're in a practice where the options are two, and I tell people all the time, I'm like, sometimes it's overwhelming to talk to us about our options because we have every option available to you. But, we try to work them through those things. And I tell them, there's sort of three aspects, particularly in breast reconstruction. One is timing. So how quickly and efficiently can we get things done? One is safety. How low is our risks of complications? And then one is the aesthetic outcome, and if you tell me your aesthetic outcome is number one, well, usually we're going to take a few risks and we're going to have to do things in more stages. And we're going to get there. We're going to make it as perfect as we possibly can. Hopefully you look even better than we started. We have the opportunity in a lot of these patients to have sort of a mommy makeover look at the end of this. But if you tell me that your number one thing is no complications, we're going to talk more about, doing delayed reconstruction, doing flat closures, things like that have no complication or much lower risk profiles. And so I try to run through those three things with each patient so I can get an understanding of, individually what they care most about, what are their goals, and we can really individualize that care and make sure that we're delivering on it in a meaningful way, and then they know what risk we're taking on. And I think that's where that individualized care is really where we've kind of really shifted our practice into. That sort of, I think, goes to the same concierge model
we talk about.
Yeah, and so we really try to maintain that. And that sort of goes along with the expectations. I think a lot of people don't expect that. And I think when you can kind of show something new that they didn't even expect, it's one thing when they come to you with a bunch of questions that they saw on the chat message board on Facebook or otherwise.
Sure.
It's another when you do something and they're like, huh, I didn't expect that. And that those are the places where you can really exceed what they wanted and really beat the model, I guess, and stay ahead of the rest of the game.
How often do you tell a patient, no, I can't do that?
Yeah.
And obviously, I say that because do you feel almost a burden that you have to, because reputation's on the line?
Sure.
There's so much of that setting yourself apart, but you also have to make the best decisions for the patient. So do you often struggle with that? And do you often tell a patient, I can't meet these expectations? Yeah.
So I think there's sort of two things. And I would say that just frankly, my partner and I probably tell more people no than anybody else I'm aware of in the city. Because it's never more important. The finances are never more important.
Correct.
Right? And you are certainly incentivized, particularly on the aesthetic side, to move forward. But our reputation is our number one thing. And delivery of those things is sort of, in the same realm. I'd say that there's sort of two things. One is, if somebody wants to do a risky operation, in terms of complication, right? So if I say hey, if you try nipple sparing, you've got a 50-50 chance that we end up with a nipple that is going to die anyway, become necrotic anyway. And they say, I want to go for that, I'm here for it. And so I'm willing to take on risk with patients that are reasonable, about the risk that we're taking on. So I try in those spaces not to tell people no. If you have a totally unrealistic expectation, that I can't meet, then sort of the typical thing is, hey, maybe I'm not the right doctor for you.
Sure.
Because I don't think I'm going to reach the goal that you are hoping to get to. And those are places where we really try to have still a collegial or congenial relationship, and it's not easy to tell a patient no. But if I truly think I can't deliver, I'm not going to do that surgery, because the patient's not going to be happy anyway. And so it's a lose-lose. And so, you know, we really, both from a practice standpoint, you don't want somebody angry in your practice for the next year or plus. You don't want to run into the liability and litigation sides of those things. And so, you know, we're pretty upfront about those things. Like I said, I'm willing to take on risk of complications. I'm not willing to take on things that I don't think are problems. There was an old saying, I don't remember who said it in plastics, but they said you have to have three things. You have to have a problem, which some people don't, and you're having that conversation. It has to be a problem that I can fix. And we have to like and trust each other. And if any of those three things are sort of lacking, then you don't move forward. And that's meaningful. And that does take a little bit of, I think, maybe just medical or surgical maturity to get to.
Sure.
Especially when I first came out, I just said yes to everybody. Same thing my fellowship director used to say. I have a patient selection problem. I don't do any. And and I always loved that. But I think as I matured, I was like, I'm going to be pretty aggressive about patient selection, because I want my patients happy. I want to maintain my reputation. I want to be happy. You know, it can be a struggle when you have complications clinic, you know, and you walk into a day that, you know, you have 40 patients and a bunch of them are have problems and they didn't feel like they were going to, and it's frustrating for them. It's frustrating for you. And I think you have to respect in medicine that no matter how good you are, no matter how smart you are, how well you trained, the program you've built, we can't know everything. We cannot be perfect. It is the art of medicine. Right. And so, you know, as long as you're striving for that and you can kind of sleep at night and you're making sure that you're picking your patients, you know, in a way that you're going to have a collaborative move through that. I tell most patients on breast reconstruction, I expect small bumps here and there, you know. There's known complication rates in every procedure that we do. But I also expect that we've built the tools and the toolkits to fix those problems. Sure. And so if we can keep moving forward, that's a success. I tell them they can get nervous when I get nervous, and I don't get nervous anymore about those things because we can fix those things. So, you know, I think staying vigilant in more complex patients. I did a patient, you know, recently with kind of a rare cold agglutinin, you know, disease, and I became an expert in cold agglutinin. You know, that something I hadn't heard since like med school.
Phys 101.
Yeah, exactly. And so I hadn't talked about that.
What stain did that could dry?
Yeah,
color?
exactly. And so I was like, you know, I'm at night. I'm like laying in bed with my wife, and I'm on the computer. You know, she's like, "What are you doing?" I'm like looking up cold agglutinin. She's like, "That's crazy." But you know, you run into those patients, and you're like, I want to be the person who says yes to people. But that's really got to be collaborative with patients. And like I said, they have to have a problem that you can fix. Otherwise, you're going nowhere.
Yeah. I'm going to throw you a little curveball. So as an internist, I take care of a lot of post-surgical complications, and it's sometimes very difficult to get that surgeon on the line or have that surgeon that really has ownership after the surgery. So talking about systems being in place.
Yeah.
Walk me through what you do. So you have the surgery. Do you have a team of nurses, or is it you yourself and your associate that go out and take care of it? Or do you find you're getting the calls from the internist saying, I have this post-op complication?
Yeah, I mean, we're pretty direct. I mean, I see my patients, this is sort of against the philosophy of most of the people I trained with, but I see my patients week one, almost always. Occasionally that's, you know, I did surgery on Friday. I'm going to see patients on Tuesday that I did surgery on. A lot of that is just, I want to check their skin. I want to make sure that there's no early complications. They don't have a hematoma that they didn't notice. I want to make sure that they don't have any questions. The worst thing is you see a patient 2 weeks later and they're like, can I shower now? And you're like, I said you could shower in 48 hours. You know, what happened? So I like to see those things up front. So we are really hands-on with our post-op care. And I do think that probably comes a little bit from the aesthetic cash pay concierge level model. You know, I recognize, you know, I sort of walked away from, like you said, you know, early on I said yes to everybody, including my referrals, right? The old thing is be, you know, able, affable, and available. And so I made myself available to everyone, including referring surgeons in town who don't take care of their patients. And so I would be, you know,
see it all the time.
Oh yeah. And I'd be the plastic surgeon, you know, taking care of like a complex neurosurgical problem or, you know, or a recurrence of their their brain cancer or, you know, and we'd be like, I would, you know, I'd be talking to my partner about this and I'm like, nobody would go see the patient even after post-op, after surgery, or talk to the family. And we'd be, you know, we'd come out after 18 hours after reconstruction and be like, hey, well, I'm sure, you know, the cancer doc talked to you, and they'd be like, nobody's talked to us. Nobody's said anything for 18 hours. And so, I think we took on that model, and so we aggressively follow those patients. I do try to stay really in touch with a lot of the people who are, because there's a lot of care that I don't do, right? I'm not taking care of people's diabetes.
Right.
I am optimizing those things.
Nor would I want you to,
Yeah.
right?
I'm optimizing those things in conjunction with,
Sure.
the internists or the subspecialists that are taking care of my patients. So we try to make ourselves really available to those people so that if they call us, I was telling a resident the other day, I was telling a recruit, somebody we're trying to hire. It's not uncommon here because there aren't integrated care models to call several physicians or several surgeons after my clinic. So if I see 30 people, I expect that I'm going to make 5 phone calls at the end of the day and just say, hey, I saw your breast cancer patient. This is sort of my plan. What do you think? Or, hey, I saw, your patient, they have cold agglutinin. Like, what are your recommendations for that? Like, what temperature do we need to keep them? And so we kind of like have those conversations. We're really aggressive about it. I know that, that doesn't happen a lot. But we do, if you call my office calls me immediately, says, hey, so-and-so is asking, questions about their patient, and we call it back immediately. So we're really aggressive about that hands-on care. I believe that, like I said at the beginning, like this is where we suffer the most, is not having multidisciplinary care, and patients suffer from those things. And so when things get missed, when there's not a available surgeon who's going to really take care of those people, and I've started seeing that as a reflection, or not a reflection, but a aspect of the patient's care that's going to make them less successful. And so, sort of conversely, if I don't have access to their internist, I'm probably going to make them find a new internist who's going to communicate with us so that we can 100%. Make sure that they're optimized in the best way possible to have a good outcome.
ParkerMedical.org.
You got it. We're into it. I mean, I think like, and what I'm running into is more and more of these, higher level care systems, in more concierge care, because the docs,
see that the job is going to get done.
The job's getting done because there is, and I think it comes almost from full circle from the patient expectation that you're going to call me back, and I mean, I have a million horror stories, but, I had a patient that, we did a complex abdominal wall reconstruction on, and ended up having a bowel issue of their anastomosis. So they leaked into, the area. It had to be reopened back up. They have an open abdomen, and I'm the only doc going to see them. And I'm like, I don't take care of open abdomen. I'm not taking care of the intestines. And so I'm happy to be there to reclose it or skin graft it or do a complex, flap reconstruction. But if you don't have
should not be taking care of that,
if you don't have that care team, everybody on board, it becomes a mess, and it's a challenge. So I think now we've been here long enough, and I trained here. We know the good and bad players, and we've sort of gravitated towards them. And when we have referrals, which isn't as common, but if I have a patient who asks me, I know the right people to send them, and I tell them a lot, like, particularly in a town like this, it's not always the shiniest billboard that's going to be the person who's going to make those calls at the end of the night. Sometimes the very marketing savvy are not the best doctors.
And that's what I had to learn at the very beginning when I started my concierge practice. I didn't necessarily have the marble floors or the restoration hardware chandeliers. And I had to remind myself that what are they buying? They're buying me.
Absolutely.
They're buying you.
Yeah.
And the patients don't care if you have everything in gold, right?
Yep.
I mean, so yes, it would be nice, but at the end of the day, patients, they don't care about that.
We always joked that everything in our office had to look nice enough for a facelift patient to sit on, but be wipeable. So they say an extremity care person with a wound could sit on it. But yeah, I mean, I think that's exactly it. And those models that people like you are building. True. And then when you do build it out, and you can have the marble floors and the things that are make it beautiful and attractive.
You finally did it. You achieved this.
You did both.
Exactly.
You did both things. You took care of the patient and made it a place that everyone wants to be. And I think I'd be interested to hear how you're like, the ways that you build, I keep calling it experiential medicine. I don't know if that's like the known.
I love that.
But like, the way that you build it so that patients come to a place they're not nervous about, they know that there's nice people around.
It's clean.
Yeah. Your staff smile and
look at you in the face when they're speaking to you.
Yeah.
They're taking their time. You can see that.
Yeah.
So
those things are meaningful to the patient, and from a business standpoint, they beget the next patient, right? And that's how you build word of mouth. Is Dr. Zamboni, one of the chair of plastics who passed away during my residency, he always said that if you had 1,000 people walking around smiling about your care, you had a self-sustaining practice. And it's interesting because that has completely shifted in the world of, new marketing, social media, those things that make it quicker to make yourself bigger. And so you sort of have to be able to do both. You have to deliver on the care side and be able to run a business and build that experience that's meaningful. Right. If you want to be the sort of next level. And
that's why I say in graduate medical education, we need to do a better job of empowering physicians to think like entrepreneurs.
Yes.
There's a whole appreciation out there, and you don't need to rely on a non-MD running your practice.
Oh, yeah.
Right.
Did you have a background in business before you started?
I have one now.
Yeah.
Yeah, I have one now.
Yeah. I mean, I think that's, I tell people, I was right when we started our practice, I had also started a online EMBA.
Sure.
And we had just had our second kid. And so my wife kind of looked at me and said, you can pick two of these things. The kid.
Yeah. Yeah.
I was like, the kid's like, non-negotiable. So you pick one of those. And I was like, it was one of those times where I was like, oh man, she means it.
Yeah.
So you start the practice where you do the MBA thing, but you're not doing both. And, but I did take the first portion of every course. And it was like, I tell people it's a vocabulary lesson, everybody's smart enough to learn it. And, I agree.
To speak to the language to it.
To speak, so you don't get railroaded in a C-suite meeting.
Right.
And I think even if you want to take it further to like the billing side for the new residents, and we try to, some of our value because the expectations from the patient side are higher, the resident autonomy in our rotation is very low. They're not doing much in our practice in terms of like hands-on. I tell every patient that they are sous chefs. They chop onions, but we do all the cooking. And so, but what they do gain is while we're doing those things, I'm talking to them about what I've been thinking about, surgically. I talk to them directly about business, and everything. It starts out early with like billing and coding up to, contract negotiations and, more complex, sophisticated billing side, more complex marketing aspects. None of that's represented in residency training, and that's really sad. Whether you go into private concierge models or you go into insurance side things,
I wish there was.
It's really a huge failure on the medical education side, and I think building that into our rotation has kept the residents interested as their autonomy has decreased significantly.
How many of you are in Las Vegas with your credentials?
Like plastic surgeons or microsurgeons?
Microsurgeons.
Ooh, I mean, if you look at plastic microsurgeons, there's really only the few that are at the university still, and then me and Dr. Brocious.
Okay.
I do expect we're going to rapidly expand, and so again, we've built a model that is interesting to young surgeons, and so our goal is to be probably in the next 2 to 3 years. I think we'll be between 5 and 7.
It's so invaluable.
Yeah, I think we want it to be like so accessible, and our goal too. Same thing from the kind of accessibility is like, I don't want to be, it's sort of a badge of honor for academics to be like, I'm 6 months out, I'm 2 years out for, these complex breast reconstructions. And like, I don't really want to be more than 3 months out, because patients don't want to wait that long. It doesn't look good for us. And I think it's sort of a misconception that that's a positive thing. That's something that belongs in academics. It doesn't belong in the private world where we're trying to get through patients, make sure they're taken care of, make sure they're doing it meaningfully. And so really, as we've kind of reached capacity on what we can do, we started being like, we need to build this out. Yeah. And sort of put those, sort of like the business aspects of, you have 6 months of care. Once that happens, people start leaving the practice. So we have to like maintain that.
Sure. How do you distinguish yourself from other plastic surgeons? Obviously, this is you have the accolades and the credentials, but how do you really distinguish yourself from other plastic surgeons? To attract patients, what would you want a patient to know specifically about Dr. Goldman?
Yeah, I think we kind of built a practice culture around authenticity. So, honestly, I think some of my staff are like, you're too friendly with your patients. You spend too long talking to them about what their, son-in-law did last week or who fell in their family or, and like, I recently started playing tennis, and like I talked to a patient for the other day for 10 minutes about tennis and my staff were going insane. They're like, we got to move on.
We got to move on.
But I think like, I think building those relationships, my partner is fully tattooed from head to toe. He wears himself literally on his skin, but he's one of the most incredible surgeons and humble people that I know. And so I think the ego of our practices is sort of differentiating.
Sure.
And in that it's less so than most. Obviously, you have to have a healthy ego, I think, to do surgery, but or really any medicine. But the way that we approach patient care, that kind of longitudinal and individualized care, and then one of the, obviously we differentiate ourselves through unique services. I think that's kind of obvious. the programmatic building, really integrating like physical therapy into those things, having connections to wellness places and things that are going to help people bounce back post chemo in ways that other plastic surgeons aren't thinking of. Those are things that I think we've really integrated too, and try to look at some person.
Hyperbaric, the benefits of hyperbaric medicine for wound healing.
Absolutely. So there are so many holistic aspects of care that are getting ignored day to day. We've tried to really round out the practice, and then building a practice that offers everything is also kind of differentiating. So we try to make it so that if you come in, most of my aesthetic patients are actually either family, friends, or of patients, or had breast cancer themselves, and now we're doing some sort of add-on thing, or they just want to get back to their lives and feel themselves again, and we're doing some sort of enhancement that way.
Got it.
And so that's been really a way that we try to differentiate ourselves.
Yeah. How is it being married to another physician and having a family and balancing personal and professional?
Yeah, it's exhausting.
Yeah.
I think, when people say that raising a kid it takes a village, it truly does. I mean, we're really fortunate to have family in town who help a lot. We have an army of babysitters. I used to tell the residents there are like 5 parts of your life. There is family, fitness, your clinical side, your non-clinical side of your job, and then a hobby. And you get to do those 5 things, but to be the best at any of them, you have to have a 0 to 10, right? So if you're gonna be the best, you're at 10, but you only have 30 points. So you have to distribute them. And so,
the word is grit.
Yeah, exactly. Easily. And there are people who are excellent at all 5. Maybe they sleep less, maybe they're a little hypomanic. But I think you have to find that balance. And so, I think as our kids have gotten older and more independent, we try to get back to our lives and find some balance on that front. I think, combining things like, my wife and I's time together is our fitness time now. We play tennis together every Tuesday morning. And that's, a release for me athletically. Sure. And it's time for us to spend together. And
you're not doing any more backflips, are you?
No, I stopped that long ago. It's funny, all of my friends.
I'm expecting that at the end of this podcast.
I would never. It's funny because I would say we would go to my teammates' weddings, and in our 20s, it was like a circus. Like break dancing everywhere. Everybody's doing flips. In our 30s, we would still do the same, but we would wake up the next morning and be like, man, my wrist hurt pretty bad.
Did I see Dr. Goldman in Atomic Saddle?
Yeah.
Is that you?
And I have friends that, were in those shows. And then now in our 40s, it's like, everybody's like, do something. And everybody's like, no. And now we're kind of waiting for our kids to do it. And so, and then, it's challenging. I'm really grateful because my wife understands, and vice versa, everything that I'm going through.
Sure.
When I have a challenging patient, I have support, at night, over dinner. She understands it. And I never really wanted that. I always kind of wanted to have somebody who was also a professional, but sort of outside of medicine. So I wouldn't talk about medicine all the time.
Yeah.
But I really appreciate that. It is challenging. I mean, we both sort of choose maybe masochistically the most challenging versions of our specialties. And so, micro is long surgeries and long days, occasional takebacks. Hers, she's on call all day. Sometimes she operates from 6 a.m. until 9 p.m. And she works weekends and holidays, and I'm
a lot of people don't see that side.
It's tough. And so, and again, we've gotten really lucky. I have 2 really good kids who, are 5 and 7, but they're warm people, and they're smart, and so they, we don't fight a lot with them when it's homework time and things like that. And so, but it's a challenge. I think finding that balance is one of the reasons I went into private practice too. The first 2 years were a lot of work. But I knew what I was building it towards, which was autonomy and the ability to control my schedule, the ability to have the kind of patience and care that I wanted to be part of, and also the ability to give my time and life back to those places where I wanted it to be. And so, I think not just expanding out so that we can continue to do more and more and more work, but expanding out so that we can build something that's sustainable for everybody involved, and they can have the kind of life and family life and, or fitness or whatever hobby that they want. And so, I have very tiny hobbies. I've become more into bonsai and things like that. But my main thing was making sure that I'm spending time with my kids, that I get to see my wife from time to time, even though we're both busy. And throughout training and throughout life, felt like there was times where your ship's in the night,
Right.
Yeah.
You have to make it a priority.
Yeah, absolutely.
So rapid fire questions. How can patients contact you?
So our phone number is 702-727-8500. That's Vegas Plastic Surgery Institute. Our website is vegaspsi.com. Those are the easiest ways. And then, we have a great front desk and a great office manager, and they take good care of everybody.
Great. What's your favorite restaurant in Las Vegas?
Ooh, that's a tough one. I'd probably say I like La Strega a lot. It's just like
Gina.
it's
Chef
nearby.
Gina.
Yeah.
Shout out to Chef Gina. You know her well.
Yeah. I love that they changed the menu. Although I will say occasionally I try something and I'm like, this is amazing, and I go back a few months later and it's gone.
Yes.
But I really like it. It's a nice, easy place to go, and
They had a really good
opener.
prosciutto fig pizza, and that's off the menu now.
Yeah, there was like a rabbit dish at some point.
Yes.
I'd never had rabbit in my life, and I was like, I'm gonna try that. Tried it. I was like, I'm going back. I went back and had it again, and then it was gone forever. They had different rabbit things since then, but that first one was my favorite thing ever. So I love it there. Yeah.
What about your favorite destination?
I try to go to Hawaii once a year. I just it's my happy, calm place, and I tell my wife my wife's like an adventurer.
Right.
So I chose for my 40th birthday. I went to Thailand, and I was like, I want to sit on the beach in Thailand.
Yes.
That's what I want to do.
Yoga.
And exactly. I want massages. I want that's she's like, I want to climb Everest base camp. And I was like, oh man,
You're doing that alone. You're doing that alone.
That might be a lonely trip, but I think Hawaii is just easy to get to now that there's direct flights, and my kids love it. And actually, my brother-in-law is doing his OB residency there now, so now we have even more reason to visit. And so it's just nice and relaxing. I think there's so much noise, not just in healthcare, but in the world right now. It's nice to kind of just shut down and listen to some waves.
Absolutely.
So studying our world, yeah.
Any final thoughts that you'd like our audience to understand?
No, I think this is such an exciting thing. I'm really appreciative of what you're doing. I think getting some eyes and ears on the building out of concierge medicine as an option for the evolution of healthcare is going to be so meaningful for the sustainability of healthcare. I really worry about the directions we're taking and how we're going to get young, smart people to keep wanting to take care of other people.
We're going to get older.
We're going to get older. I think my generation is going to be one of the last. I'm watching the next generation just say nah, and I think building models that are sustainable with groups where you can be successful, you can take care of patients in the right way. That's heavily meaningful, and so appreciate what you do. Thank you so much for having me.
Well, if we can help with any of your patients, we definitely truly believe in the concierge model and providing that access and that care that I always say, medicine practice from a simpler time long ago.
Oh yeah.
So, Dr. Goldman, thank you for being on Out in
It was a pleasure. Thanks for having me.
Dr. Goldman, thank you so much for joining us today. Your insights into surgical practice, concierge-style care, and physician-led innovation were completely invaluable, and we are truly appreciative of you taking the time to be with us today. And as always, a special thank you to my co-host, Dr. Rishi Seth in Tampa. Your perspective and thoughtful commentary continue to elevate every conversation we have here on Out of Network. I miss you today. To our listeners, thank you for tuning in. If you found today's discussion helpful, be sure to subscribe, share the episode, and leave us a review. We'll see you next time on Out of Network.